Ever since the advent of lasers in ophthalmology, they continue to hold sway in the treatment of various retinal disorders, even in the face of threat from newer treatment modalities. This animation video attempts to highlight the basics of laser treatment for common retinal disorders that is intended to help the resident or the novice fellow. Diabetic retinopathy is the commonest disease that warrants laser treatment. The proliferative form is treated with a pan-retinal laser photocoagulation protocol. Laser burns of 400 to 500 micron width are applied with a spacing of 1 burn width and continued over the whole extent of the retina, taking care to avoid major retinal vessels and areas of large superficial hemorrhage. An area of 500 microns around the nasal disc margin is also avoided to minimize thermal papillitis. Some prefer to place a row of burns 2 disc diameters temporal to the fovea first to avoid inadvertent macular burns. A grid of laser spots similar to a pattern scan laser may also be placed using this animation. In patients with early vitreous or preretinal hemorrhage, the inferior quadrants are first treated, as this zone may become later inaccessible if a dependent vitreous hemorrhage were to develop. In patients with coexisting PDR and CSME, the nasal and inferior quadrants of the retina are first treated along with the macula, and PRP carried out over the other retinal areas in a phased manner to avoid PRP-induced worsening of pre-existent macular edema. In patients with recurrent bleed after a PRP, a pattern tightening laser augmentation or laser fill-in will help stabilize the retinopathy. In patients with diabetic macular edema or the CSME, the angiogram should guide laser treatment to the leaking lesions. If treatment is based on the color fundus photograph, it may result in indiscriminate laser treatment to the delicate macula, causing needless damage to the photoreceptors. When the leaking lesions are not obvious and there is a diffuse leakage from a leaky retinal capillary bed, a grid pattern of laser photocoagulation using light burns may be applied after good systemic control and or in conjunction with pharmacotherapy, taking care to avoid treatment along the papillomacular bundle. The results of such treatment are not always bleak, even in seemingly dismal situations. Branch retinal vein occlusion is the second most common retinal vascular disorder after diabetic retinopathy. When complicated by vasoproliferation, a scatter pattern of sectorial laser to the ischemic retina is applied, similar to diabetic PRP, taking care to avoid treating collaterals. Although anti-VEGF agents have largely supplanted laser in the treatment of CNVM, select extrafoveal membranes are still amenable for laser treatment. Here, an overlapping tight pattern of laser is done and is carried around the choroidal neovascular membrane for about 100 microns in order to achieve complete ablation. When central serous retinopathy is to be treated with laser, the earliest FFA frames showing the leakage point is to be chosen and a light laser burn applied precisely over it, provided it is amenable to laser treatment. If a later frame is chosen, it leads to an unnecessarily large area of treatment with its attendant complications. Retinal breaks predisposing to retinal detachment need prophylactic treatment. Here, contiguous laser burns around the break in 2 to 3 rows are given, as vitreoretinal traction is thought to extend beyond the retinal break that is visible clinically. The above animations can be easily made using the software that is available in any computer system. The color fundus photograph is first taken onto the computer screen. We go to Insert, move on to Shapes, select any shape, an oblong shape or a circle, copy it onto the area of the color fundus photograph where we intend to place the retinal burns. Go to Animation, Custom Animation, and then choose Add Effects, and this has to be superimposed on each of the spots that have been cut and pasted onto the color fundus image. It is a useful review tool and also a good source of simulated laser delivery that may be practiced over the computer screen on an actual fundus photograph before laser delivery to the patient. The only currently available teaching tool employs a monocular assistant observation tube connected to a beam splitter on the slit lamp, and even this is not universally available. To the best of our knowledge, our animation technique is the first of its kind that elegantly demonstrates laser techniques and allows the greenhorn a simulated hands-on experience on the computer, wherein successive laser spots can be delivered by the click of a mouse or by pressing the advance button on the keyboard. It can also be used effectively for patient education.